I think we'll go ahead and get started. All right, I'm Kristen. I'm one of the RWJ scholars, and I'm very excited to welcome our first IHPI research seminar presentation of 2016. We're delighted to have Dr. Ariel Linden to help us open a year of enriching and impactful research discussion. So Dr. Linden is a research scientist in the University of Michigan Division of General Medicine and an adjunct professor in the Department of Health Management and Policy. He began his healthcare career as a clinical scientist in the areas of cardiovascular and pulmonary physiology. He completed his Dr.P.H at UCLA in health services research in 1997 and extended his expertise in clinical research to measurement and evaluation strategies of large-scale and population-based interventions. His research interests range from evaluating the effectiveness of clinical and behavioral interventions for chronically ill patients to characterizing measurement issues among this patient population and to developing statistical software programs. Please help me in welcoming Dr. Linden for our talk today.
Hello, everybody. Thanks for coming. I know that on a beautiful sunny day like this, you'd rather be outside, so I'm actually surprised that anybody's here whatsoever, but thank you for coming. I originally thought about presenting this based on the title. I said, you know what, I can bring in my work and talk about how I use these different models and go in details on each of these studies, and I thought, you know what, this is not going to benefit anybody. If at anything, after 15 minutes, it'll put you all to sleep. So I said, you know, probably what would be beneficial would be to talk about the thought process that I go through when I think about doing a study. And that's something a lot of people that never really learn. They learn it on their own, but there's not a formal process that says, here's how you think about it. So I thought, you know what, let me go through a presentation where I actually think about, where I discuss the thought process for at least how I think about conducting a study. And as it turns out, after the fact, yesterday in fact, I come up to this little article in the New York Times in the business section. It's completely unrelated to my talk, but it's very poignant nonetheless, and it dawned on me that there are synergies here. So what does that mean? So this happens to be about a study or a newspaper clipping about doctors, hospitalists in Oregon that they unionize. And the basic premise for why they want to unionize is because the doctors want to spend more time with their patients. Why? So they could diagnose them better, so they know how to do the better treatment. So what stood out to me, and I'm sorry you can't see this very clearly, but it says, eventually Dr. Alexander would, after speaking to the patient's family, after the patient's hospitalized, so he's spent some significant amount of time with the patient's family, says eventually Dr. Alexander would discard the most exotic theories that had crossed his mind, why the patient was hospitalized, meningitis or possibly a condition known as serotonin syndrome, and settle on a far simpler malady, dehydration, which aggravated a chronic kidney problem. And it dawned on me, you know, I didn't invent this stuff. Doctors do this every day. The difference is doctors do this on every single patient that comes through. And I'm talking about doing a research study. You know, you don't do research every day, but you go through this process nonetheless. So there are not only synergies, but actually, hopefully from an investigator perspective, this will create the same sort of neural pathway for thinking, okay, if this is the way I think about treating a patient, diagnosing and treating a patient, maybe I can take a step back and think of developing a sort of pathway for conducting research. So that sort of added another level of confidence that my talk is on the right track when I saw that. So the way I'm going to create this sort of presentation is think about it in terms of an ice sculptor that has this big block of ice and then has to figure out, knows generally what they want to create out of it, but you start whittling away, and every time you sort of whittle away at it, you sort of get a little bit more clarity, and based on the clarity of where you're going, you then know where to go from there until you finally have a finished product. Well, that's sort of the way I'm going to present this, because that's sort of the way I think about things. So we start off using a particular framework to ask the right kind of questions, so like history and physical and things of that nature. Then based on that, the questions, then you think, okay, what is the best, most robust study design that I can apply? This presentation is focusing on observational studies as opposed to randomized control trials. Those are pretty straightforward, easy to do. You do all the hard work of the the RCT, and then the analysis is pretty straightforward and easy. It's when you have observational data is when you have all sorts of problems and complexities. So we're focusing on observational studies. And so there's 3 categories I'm going to talk about. And then once you've sort of whittled it down to the best of breed study design to answer those questions that you've had answered, then you sort of visualize, how do you anticipate this looking at the end? And then starting with the end in mind, you sort of all bring this down to the end. So, and then after that, I talk through that, then I'm going to give you some examples. I can't let you leave here without giving some real life examples, or else you'll think I'm making this, well, I am making this stuff up. But at least you have some examples to go by. Okay, so what is a Pico framework? It actually is interesting enough, the people that introduced this were research librarians. And it's because they would interact with clinicians that wanted to write a paper, and they would ask these questions of them because they needed to go and do the research, the background stuff, and they would ask these set of questions. It turns out these set of questions are what a researcher should be thinking about up front. And I use this, maybe not exactly the same, but I actually use this quite a bit, this basic general framework. So the first P in the Pico framework is, what is either your individual patient or your population or the problem that you want to study? So if we're talking about observational studies, it's typically something like, what is the population you want to deal with? But if you're talking about a clinical study or a very small subset or case studies, you're talking about patients, or what the problem is, or patients and the problem, patients with a subset of conditions or whatnot. Next is, what is the intervention? Now the intervention, a lot of people immediately skip over that when they want to do an evaluation. It's like, okay, the intervention's the intervention, I don't care about that. Although the truth of the matter is, I could spend here probably 4 lectures just talking about the intervention. Not how to do the intervention, but the things that you need to tie in from the intervention to the outcome. Causal pathways. You can't just make the assumption that you do an intervention and it's enough that you say you've done the intervention, but now we're going to immediately jump to outcomes and call it a day. If your intervention is not effective, you're not going to have any outcomes. So why don't you start with making sure that your intervention works before immediately jumping to saying, it works, now let's just evaluate it. And do you have a comparison group? If so, who is a comparison group, or do you even possibly have more than one comparison group? This is where they usually stop at outcomes. What is your outcomes? But I really like the added T in there, because in nearly everything that I do, the T ends up becoming the most important part of all of this. So what does it mean? The time frame. So there's 2 main time frames. One is the time frame of the intervention itself. So you implemented the intervention. How long did the intervention go for? Then within that, it gets broken down to, well, how long do you think the intervention will take until it's effective? Is it giving a pill, and the next day the patient is, or the group of patients I'm under study all of a sudden are now in diabetic control, or they're within normal ranges of within their physiologic measurements? Or do you think that you're implementing something that's going to take some time to get legs and to take root? So that's the time frame for the intervention. Then from the evaluation perspective, you have to think about, how much time do you have available, meaning how many of your data do you have prior to the intervention? How much do you have after the intervention started? And even more so than that, what kind of data do you have? Do you have aggregated data in the pre-period and aggregated data in the post-period? Or do you have it granular where you can actually have regular observations over a period of time? All those kind of things under the time frame really help elucidate you where you're going to do a time series model, a longitudinal model, a pre-post model, and all of that. So I really like that additional of the T in there, but this is sort of the basic questions I ask. So let's give an example. So let's say there's a disease management intervention. I didn't make this up, because disease management used to be an entire industry in and of itself. And the questions there are pretty, the sort of standard frameworks are nearly universal. Question, who's the population? So this is actually off the Medicare demonstration projects that evaluated disease management. The population is Medicare recipients with congestive heart failure. They also had it for COP and diabetes, high risk, high cost, things of that nature. The intervention, almost inevitably, was going to be monthly calls from a nurse, outbound calls from a nurse to the patients that are classified as high risk. And then if their patients are considered low risk, then they just send them educational materials. So it sort of helps to know what the intervention is, because then you can decide from outcomes, maybe you're going to have different kind of outcomes, maybe you're going to stratify, maybe you can put in here a mediation model where you're going to look at the causal pathways. Comparison, in this case, well, you have an entire Medicare population that you can then narrow it to those with congestive heart failure in the same age and risk strata that are not participating in the study. So I italicize comparable because comparable is the operative word in non-randomized studies. And then time frame, outcomes, hospitalizations, ED visits, and total healthcare costs. And a time frame is one bulk pre and a post. So when you start thinking about this, okay, so these are the main questions. I now know sort of where I didn't put in here data source, but data source, we know it's going to be Medicare data. We know how much data we have available. We know what the outcomes of importance are, whether it's for us as the investigators or for the policymakers, the government, federal government. We know the population and where we can draw from. So that's an example. So the next part of the thought process for me is after I've got those questions, I'm saying, okay, so I know in general I can go, in this case, I can't do longitudinal model, but I know I have 2 time periods. I know I have a control group that I can create. So now I start thinking about how am I going to ensure that I have the highest amount of internal validity in my study. I know I can't, because this is observational, I don't have a RCT. So as soon as I start stepping back from the RCT, I try to stay as close to that as possible. And I certainly don't want to go to the other extreme, which is a pre-post with no control group. And of course, if you have the data to support, there's no reason not to create some sort of a control group. And if you have the data to support it, there's no reason why not to do longitudinal data assessment as opposed to just aggregating it all up into one big pre-period and one big post-period. So again, for the purpose of this presentation, we're sticking with the most robust designs in the observational realm here, which according to Campbell and Stanley, they qualify these as quasi-experimental. Okay, so when do you use these kind of designs? First and foremost, I'd say when randomization is infeasible. If your go-to tool is going to be an RCT, nobody's going to question. Well, there's always going to be people questioning the validity of your findings. But there's going to be a lot less questions about the validity of your findings if you can do an RCT over observational. So you shouldn't start off with, let's do an observational as opposed to an RCT if we have the ability to do so. But there's a lot of reasons why you cannot do an RCT. You can't get the grant funding or the support from your organization. There's ethical reasons. What you want to study, you have to subject patients to or expose them to things that may cause harm. So you'd like to study them, but you can't expose them to something that might cause harm. Or there's legal constraints. In many cases, you don't have a viable control group, and you have to think, well, if I don't have a control group, then what am I going to do? And so there's ways around it. If you don't, you can still come up with a robust design if you don't have a control group. And you say, when would you not have it? Well, if you're going to expose everybody to the intervention, or you're going to expose so many of them to the intervention and there's not that many people left that would be suitable controls, they're not comparable, or you can expose an entire city to, or county or whatever or expose them to a campaign of some sort, then you can't take people out and assume that they haven't been exposed to this at some point. So sometimes you don't have a control group. And sometimes you do an RCT, but it fails. Somehow the blinding doesn't work. You end up, there is some element of self-selection, or either self-selection because the blinding didn't work, or there's the people that are supposed to be triaging or randomizing them or allocating them the randomization, they somehow say, this patient looks really in a bad state. I'm gonna just slip that person over into the treatment. Unfortunately, it happens. when you go then look at the characteristics of the two groups at baseline, all of a sudden you come to realize these groups are not comparable. In that case, you might continue it, but you can't call it an RCT anymore. The element of randomization is no longer valid. And sometimes a lot of the stuff of what we do as health service researchers is observational data. You have secondary data, so you cannot start off with an RCT out of it. The next step I do go through is I think, okay, what are the main threats to validity? You can't solve world hunger in an observational study. You cannot control for every threat to validity out there. So you sort of have to pick and choose, and it's a balance between as many of them as you can. This controls for as many of the threats that you can out of it, but probably even more importantly, there's one or two or three that are just pop up to the top of your list that everybody's going to argue that your study sucks because you did not control for this, this, and this. And you sort of know that based on your expertise, whether it's a clinical expertise or whether it's sort of the setting that you're in or the type of data you're collecting. So very briefly, history is, again, Campbell and Stanley's, which they came up with this in 1963. They were thinking about this already in the late 50s, and it still resonates well. Not necessarily the nomenclature, however, the thought behind it. So what they called history is nowadays called secular trends. You might conduct a study, and just as you're doing that, all of a sudden there's a huge media campaign, sort of will bias whatever result that you're having because it could be due to the media campaign, or it's in the newspaper tomorrow, or your peer organization has decided to disseminate some practice guidelines that talk about it, and it sort of screws up your study. Maturation, something that people don't necessarily think about it, but if you're going to do a study over time and you have patients in this that, again, mature or they have a disease progression, they're going to learn about their conditions as they go. And on their own, they might learn more about it, and they might independently then change their behaviors that have nothing to do with the study, but all has to do with the aging process or the disease progression. Testing, I see an inordinate number of studies where they give a pretest to assess a patient's knowledge about their condition, their disease. And then they go in at the end of the study, then they do this again. And they report how wonderful everybody in the study now increased their knowledge, their disease knowledge. And nobody stopped to think about, maybe this is an educational tool and this is your intervention. Outside of your intervention, just tell them, if once they come to realize that they don't know enough about their disease, maybe they're going to learn about it. Or maybe you tell them you say, do you know anything about this medication? And they say, I don't know anything about this medication, but thanks to WebMD, I'm going to learn everything I know. And then they take action accordingly. Instrumentation, you might measure something using a tool, the SF36, and then you decide you're going to use the SF12 later. In that case, it works because it's a subset, but the validity of it obviously changes when you're taking only 12 questions versus 36. Or you decide to use one kind of a measurement, and then afterwards you're going to use another measurement tool, or even your unit of measure changes over time. I'm a very big fan of controlling for regression to the mean. It seems like this pops up everywhere, but few people actually consider this in their evaluation. When you identify up front people you want to participate in your study because they are outliers, they have extremely high values of hemoglobin A1C or extremely high blood pressures or whatever, and then you decide to take from your population other people with high blood pressure, but they might not be as high, you have these people that in the next measurement are going to regress down to the mean, whereas everybody else that's closer to mean already are not going to regress. So you look like, wow, we really did a lot for in this investigation by getting these people with high blood pressure down on the second measurement, when in fact a large portion of that is nothing more than regression to the mean. Selection, you've got either self-selection or you've got selection due to the investigator sort of triaging people into the study, and those two in most observational studies play together, the regression to the mean and the selection issue. You've got attrition. Naturally, if they're not comparable on baseline to treatment in the control group, they might have differential attrition, and then the whole host of interactions between selection bias, and all these other things. So what I start to think about as we're going down the process is which study design meets the criteria that I need based on the data, and in which is going to be the most valid in terms of controlling for the most important things. So I'm going to focus on these sets. The first set is non-equivalent control group, and that's basically nearly everything that we're ever going to play with just under that title. It's either regressing the outcome on the treatment with a bunch of covariates, difference in differences. Everybody in this room has probably heard difference in differences at least once or twice or 50 times, or matching or weighting. And again, I could probably spend 3 hours on each of those just going through those, but the purpose here is, and most people don't even actually stop to think about, those actually sort of fall under the same rubrics here of being a non-equivalent control group. Equivalent is a term that that is associated with a randomized control group because they would be equivalent to two groups because of due to randomization. The best you can do in an observational study is comparable, and even less than that, comparable on the observationals, the observed variables that we have available to us. And we hope that then, if we can control for those things, that on the unobservables, they'll be balanced as well. The data may be pre-post, 2 periods, or they may be longitudinal. They still fall under the same rubrics of being a non-equivalent control group. And you might have one control group, or you might have a whole bunch of them. So this is a nice catch-all category. I find a tremendous amount of use in either single or multiple group interrupted time series. You use those when you have data that are usually aggregated, but you have a whole bunch of time periods that are equally spaced in the baseline period and in the out period after that. And it controls for several different biases, in particular regression to the mean. And then one that I'm enamored with, but don't find many opportunities to use it, is a regression discontinuity design. All right. So we're going to now focus on the first one, the non-equivalent control group. When are you going to use it? When a comparable control group can be chosen out of a larger pool of non-participants. When you have both the pre and post measurements available, and meaning baseline and outcomes. And then when you're either interested in knowing what's the difference between the two groups on the outcome variable, or if you're interested in knowing what the difference in difference is, the change between the post minus the pre for the two groups. When you think about that, again, it basically covers probably 80% of the scenarios that you're going to come up against when you're doing some sort of an assessment or evaluation of control group data. Okay, and then I think, okay, so now I know I'm going to do a non-equivalent control group. What does it look like? How do I, if I think about the end, I'm going to do the analysis. What would it look like if I wanted to put it up? Now, obviously, this is made up data, but I like thinking about things visually. What is it going to look like? It doesn't necessarily it's going to go this direction. It might crisscross or whatever, but I think graphically how it would look, it sort of sets my sights on where I'm going to go, and then does this design actually make sense? So what we see here is, again, this is Campbell and Stanley's sort of X's and O's. The O's are the observations, the measurements. The X is one non-randomized group gets the intervention. And what you see here is 2 scenarios. The one group, you implement an intervention here. So in this case, both groups are going up. So how would this look if you want to evaluate it? Number one is, okay, if I really want to ensure that the groups are comparable, then they better be, on the baseline, they absolutely positively have to have an overlap, at least in their confidence intervals, but they should be nearly identical on that first observation. You can take this to the next level and say, if I want to do a difference in difference, and you can see what that measurement looks like, it's basically, for the treatment group, O2, the observation second minus the first, and the control group. that. And in fact, you can do multiple difference in differences by having even another group in there as well. So you can see that this isn't a set, a sort of a set deal. You can actually interact, not only ensuring that the groups are comparable, but also then use it in a different framework, which is a difference in difference, and it makes it even more robust. So this is how I think about using it for a non-equivalent control group. But there are, again, thinking about, well, what is a control for, what is it not control group? So this is, again, going back to Campbell and Stanley, and I don't necessarily agree with everything that they say that it controls for, because I think it very much depends on the situation. They assume that the groups are comparable. This is before the time of matching, propensity score matching and stuff when they wrote this, which only came about 10 years after that. But they assume that the groups are comparable. And if they are, then you see it basically, well, whatever happens here should happen to both groups comparably. The thing that they have a question mark about is regression to the mean, and their argument is that even if you do match, if the groups are comparable, you still might have one that's going to regress more than the other, and my argument would be that gets taken out if the groups are comparable on that pretest value. If you matched, ensured that everybody in there, let's say you have a blood pressure trial, and everybody there has a blood pressure over 150 or average of 150, you better find controls that have blood pressures of that. You can't make them if they have a blood pressure of 120, even though you can weight them or whatever to adjust to make them appear like they have a blood pressure of 150, but obviously that's not the same as actually having a blood pressure of 150. And if it's high and you do anticipate the next measurement is going to regress downward, you can't control for that in the study design. All right, jumping to a single group ITSA, interrupted time series analysis. So when are you going to use this? Well, if, again, you have aggregated data, so you don't have the details on every individual in the population, every study participant, but you collect monthly or annual data at the highest level. This usually aggregated rates or mortality rates, whatever you can is available that gets either advertised or put up on the web or in your own organization, that they can only aggregate it. But it's for a single unit. So we're going to do a study in a hospital, and we don't have data from other hospitals to compare against. Or we're going to do a media campaign in a particular county, and we can't necessarily compare. We don't have the statistics of other counties. So you have one unit of measure here, but you in fact do have all these rates that are reported historically. And the longer you go out historically, the more you can control for these things, these concerns as you look outward. You can add a control group to this or more, and that's a multiple interrupted time series analysis. It makes it even more robust. But what's also valuable about this design is you sort of have two different, of your outcome, you can look at it two different ways. One about the immediate step function, which is what happens immediately after we implement this? Does this have an immediate effect, this intervention? Or does it have a trend? Does it occur over time? It might not occur right away, but given enough time, we start seeing that the behavior of the outcome starts to go in the direction we want. And you can learn from that how long, at least in this particular study, does it take for it to appear to have an effect. So how does that look? Well, it looks like you would anticipate a lot of measurements equally spaced in the baseline. Then you have your intervention, which is supposed to interrupt the pre-trend, the level and the trend prior to the interruption. And then you sort of expect after the intervention is put into place that both there's going to be either there's going to be immediate jump right here, or that you think it's going to take over time that you can then measure the trend over time. You can end up measuring both of them, but sometimes you might have a null effect on the immediate impact for all the obvious reasons. Some things take a lot of time until they take root. Here, the main reason why the interrupted time series achieves its validity is because given enough time, you think everything is sort of to come out in the wash. if you're going to have some jumps due to secular trends, if you think that are away from that exact intervention point. But if people are going with disease progression, instrumentation, all these things, well, if I measure enough of the time, I'm going to be able to smooth it out and tease out an intervention effect from noise. And you can't do that if you only have 2 data points. You can obviously think now, okay, well, if I have individual patient level, that makes sense for doing a longitudinal model because I have the benefit of having all this historic data to get rid of all the noise there, plus the intervention. So you've got all this additional benefit to having multiple measurements involved. What I highlighted in red here, even though they give the check mark of saying, well, we don't have any selection, we don't have any attrition, I would argue that only holds if it's the same people being measured over time. Because you can't have selection bias if it's the same people being measured. There's nobody to choose from or self-select from. But time series analysis could be either individual units that are being followed over time, or they could be based on the measurement cross-sectional. So you have hospitalization rates. Well, they're not the same people are being hospitalized every month, or ED visit rates, or mortality rates. They're obviously different people. In that case, who those people are, make that up, may in fact actually lead to selection or attrition bias. So again, multiple group makes the single group much more robust, because now not only can we say, did the single group improve in the post-period minus compared to the pre-period, but now we have a comparator that goes against that as well. So now we can see the single group, and as it turns out, in many cases you're going to see an effect in a single group, but as soon as you compare it to another group, all of a sudden that improvement dries up. So it's always better to have a control group if you can find one. And the threats here you can see, when you have a control group, it nearly now controls for everything except a question mark about the selection bias. Again, if you're going to find some group to compare against that makes no sense as a comparator, then you may in fact have selection bias there. Regression discontinuity. This is a beautiful design. This is, most people in this day and age will classify this as good as randomized. The idea, generally speaking, is that you have a continuous variable of which you then have a cutoff, and you, as the administrator, you ensure that the people that are going to get the intervention are either above that cutoff or below that cutoff, depending if you think they're going to go down or you think they're going to go up. The beauty of this is, and the basis for the validity, is that you believe that the individuals that are being assigned to here, they have no control over where they're going to be, obviously self-selection. So if you got this blood pressure study, that they can't somehow change their blood pressure to make them qualify for this study, or hemoglobin A1C, they're not going to be able to influence that in a manner that all of a sudden will then put them in a treatment group. So the idea that they don't have, that they may not know exactly where that cutoff is, the people that are getting sent into this intervention, but also that they have no control over changing it so that they can in fact get into the other side. Now there's ways of adjusting this, but for the most part you want to make sure that you try to keep it as a strict design. So how does this look? We visualize it. Well, let's say we have this pre-intervention assignment variable, and we have this cutoff, and we say everybody below the cutoff is over here, and everybody above the cutoff assigns there. And what you want to know then is what sort of the trends of this group look below the cutoff and above the cutoff, and most importantly then, what the treatment effect is what is the difference in the outcome, which is on the y-axis, here the difference in these two trends. So you can see this is very similar to an interrupted time series analysis. Although instead of this being time here, you have some sort of cutoff on some continuous variable. And that was the intention of Campbell that came up with this design that said, hey, it's basically more or less the same thing. Now, there was a lot of problems with this original design because it assumes linearity, right? So it would lie dormant for many a year, and then the econometricians got hold of it and figured out how to improve it. So what did they do? This is relatively recent innovations with this, which is actually phenomenal. What they said was, because we don't know what the trends are, and we cannot assume that they're linear, and if they're not linear and we take everybody on this side and compare them to everybody on that side, then you have some statistical issues involved here with misspecification of the model. So what can we do to address that? So the first thing is that they came up with was creating a neighborhood around the cutoff. There's a simple way of doing it, and there's a more complex way that's algorithm generated. But basically what you're going to say is the people that are in the neighborhood of the cutoff should be the most comparable. If it was a randomized control trial and a virtue of the randomization process, they would be comparable. You think about it this way, that if you have a blood pressure criteria of 150, people of a blood pressure of 148 should not be all that different from people that are 152. Especially if this is a continuous measure. There might be differences if you set your blood pressure at 120, and they might be people below that or above that, or how wide your neighborhood is. If you said, I'm going to set my neighborhood criteria at 10 points in either direction, then you can start arguing that they're not all that comparable. But the idea is to create a neighborhood where you believe that the people are the most comparable. And therefore, when you go to look at the treatment effect here, now you've narrowed it. They call it the local average treatment effect. So the comparison is as opposed to everybody in here, only in this little narrow category. And not only that, but they've gone from a sort of a straight up regression model to now doing 2 regressions on either side, local linear regressions that are more flexible in modeling the data. So this is with this new improved regression discontinuity design, it's considered as good as randomized. So you can see this pretty much controls for everything except, you ask about instrumentation, and there, according to Campbell and Stanley, they bring up a good point. It says, look, if you have people calling the patients and asking the particular questions over time, either by group or over time or both, then they might be asking the questions differently. And if so, then it's a matter of the scorers might be introducing bias. And attrition, because you measure it on a baseline period, and then let's say the next year, so you might in fact have differential attrition over time. Again, this is, if they're supposed to be as good as randomized, you don't expect people within that narrow neighborhood to have differential attrition, but it nonetheless is a threat. All right, I can't have a presentation that doesn't have any math. And so you think, okay, showed the pretty graphs, I've talked about the biases. How does it typically work? Well, first of all, the first one, this is a standard fare. This is either a t-test or in a regression framework where you're basically regressing your outcome on a treatment variable. But we know it's biased because we have no covariates. So the next one is basically an enhanced version of the same thing where we throw in some additional covariates. And again, whatever is highlighted in red makes it pretty straightforward because that is the value, that is our treatment effect estimator, the parameter that's our treatment effect estimator. So no matter what you throw on the right side of the model here, as long as you know that you're focusing on the one value that's going to indicate whether your treatment was good or bad or indifferent, that's where you go. But again, the purpose in showing this is saying almost everything we do can be analyzed within a regression framework. You can enhance it by matching before that or sort of limiting the stratifying, but ultimately you then can use this within a regression framework. So people that understand regression, if you pair the regression formula with the fancy graphic and the threats to validity, you can see that they all ultimately tie together. Okay, so very quickly I'm going to go through 3 examples. So here's a medical home pilot, and again, the logic here is thinking about it in the Pico framework. And so this was a study I think I did 15 years ago. There was 374 patients, and it was a primary care practice that was thinking, this was before the medical home was actually called a medical home, but they said, we're gonna try to do some enhanced primary care. And the idea is we're gonna identify people either have chronic illnesses or that are high risk for incurring costs next year, and we're gonna give them some enhanced primary care, which translated to we're gonna hire a couple nurses and we're gonna have them make calls to these patients and spend a little bit more time with them. And we believe that should help them follow the physician's recommendations, treatment plan, and then keep them from ending up in a hospital. We had a comparison group. So you notice there is there are individuals that were not in intervention that were available for comparison. There was 1,628 of those. And the outcome that they were really interested in was, can we impact costs? Can we reduce our costs over time? So given that, you think, okay, so what kind of a design we have? We have intervention group patients. We have patients that we can then cull from to create a comparison group. And our outcome is a change in costs. And we had aggregated baseline costs for the year prior to the intervention and costs in the year post. So I know I can't do longitudinal analysis here. So the design I chose, which is in the framework of a non-equivalent control group, is one-to-one matching on a propensity score. I'm not going to go into details what's a propensity score. The idea is it's a matching algorithm to make sure that the groups are comparable. Why did I choose that? Pragmatically, I chose it because you can show a table of baseline characteristics where you can demonstrate they're comparable. So if I choose a set of control patients that look and feel like the treated patients, the end users in this, which were the physicians and the physicians and the physician executives, could say, okay, I believe now that the patients are comparable. More importantly, I chose one-to-one as opposed to sort of weighting or matching more than that, because they felt if they saw a group of patients, they're comparable here, and where they went, it's tangible to them. If I start saying, I use this adjustment technique, and I weighted, and trust me, once I weighted them, now they're comparable, no one was going to believe me. So one-to-one matching pragmatically, and as it turns out, most people use this design anyways. So now, what did I envision and how did it turn out? Well, as it turns out, there was a drop in the treatment group from the baseline to that. There was a slight increase in the control group, but you can see the confidence intervals are huge. Costs were going up, they were going down. There was no significant difference between them. So that's an example of a medical home pilot. And an ACO, Accountable Care Organization, it's hot topics these days. A few years ago, I did an evaluation on an ACO before it was, these were getting implemented as a widespread activity. And this was a statewide initiative, can't tell you what state, by a large health plan, can't tell you which health plan. But they were contracting with ACOs and they started implementing, and they wanted to know if it's working. What do they care about? So there was one ACO that they wanted to focus on, the largest in that state. The intervention in this case, where they were going to contract with the health insurer under the auspices of reducing what they call in industry the cost trend. Bending the cost trend, or bending the cost curve to be more precise. I had 5 groups that I could use for comparison, large groups that were, other than the name ACO, they were ACOs. So they were good comparators for that. But given that you think about it, so I only have very small number of units to measure here. And I had a lot of monthly data to go by. You can see here 12 months of baseline, 18 months of follow-up. So it makes sense I could do either a single group, but I had comparison groups. I can do a multiple group ITSA. So what did that one look like? Everybody wants to know. Inquiring minds want to ask. So all you need to basically look is at the lines here, and even more so what they were interested about. Okay, if we align them and we look in the trends going outward, those babies are parallel. In fact, you can see some of the black dots over the empty over the empty dots and the empty dots over that. So you can see that there's no difference here in the trends, which was too bad because they had this whole contract and they were really promoting the ACO as being as good as it gets. And you can see 18 months out, there's no difference in the other groups that didn't have that particular contract. And lastly, we had a health management program that was, it was a pilot. Implemented on the West Coast somewhere by a health insurer, which I can't tell you who it was. But they said, you know what? I said to them, look, I know you don't want to randomize, but let's try this. Let's see how this works. You give everybody a risk score. So let's find a sort of a break in the risk score continuum where we think that beyond that there's sort of a real upslope in costs. And below that there isn't. And let's find people in the neighborhood of that, and then you can give your intervention. I said, this is better than, or this is an alternative to doing a matching kind of a study. And I said, okay, sounds good. So we had 184 people which had a score above that. And you can see it goes all the way up to 798. Like the scale of the risk, it's commercial risk tool makes little sense. But the fact that everybody's subjective to the same risk scoring mechanism at least gave some sense of confidence that I can cut there. The interventions, nurses made outbound calls and they try to coordinate the care. And then a comparison group where I had about 1,500 people that were below that. And the outcomes, again, we're going to look at the change in cost from the pre-year to the post-year. And I had a baseline year and a program year, so what am I going to go with? Once you know I've got a continuous variable and I did a cutoff, it sort of gives away the secret. So I use the regression discontinuity design here. What do we see here? We don't see anything here is what we see. So this was 100 points on either side of that, and we can see that is near complete overlap in that intervention did not work in saving money. Difference in costs. Okay, so putting it all together and sort of coming back to the beginning of how do you think about this? So while physicians on every different patient sort of go sort of a ritualized manner of trying to tease out what are the problems and what are you going to do with this patient in diagnosing and what does that lead to, and then you're going to try to stay away from the craziest, probably least likely of diagnoses that this patient is coming in with, obscure conditions, and probably focus on the ones that are most obvious and try to treat those. This is the kind of thought process that you want to develop for yourselves as you think about every research project that comes your way. What kind of data do you have? You think about it within a framework. I like using the Pico framework, but you could certainly develop your own or take bits and pieces. Think about the most important questions you want to ask about the data available for you. How long of the data do you have? When did the intervention participate? Do you have viable control group? All these kind of things that you want to think about. And once you have that, then you think, okay, based on that, what is in my tool chest of designs, and of those, what are the most robust to address at least or control for the threat of the bias that I'm most concerned about? Is it regression to the mean, selection bias? Is there temporal trends that I need to overcome? Those kind of things. And something that I do fairly often, because you're always going to get pushback when you do an observational study design. Well, it's biased. There's nothing you can do to counter that other than says we've controlled for everything we possibly can control for. However, if you have data that's in a certain, that you could theoretically analyze in more than one different manner, analyze it in 2 or 3 different ways and triangulate. And if you find, at least directionally, you're getting the same result, you can then say, you yourselves will feel more confident that the result is real. But you can also help sort of provide the reviewers more confidence that your results are real too, when you've looked at it 3 different ways, 3 different lenses, and sort of getting at least directionally that it's the same sort of effect that you're getting, or anticipated effect that you're going to get. Well, thank you very much. a couple things. I spoke fast, had a lot of slides, recognize that fact. So we have this taped. The slide deck will also be made available to you. And I'm always available for discussions about your research designs if you have questions about the presentation. I apologize that I speak so fast. There's nothing I can do about that. All right, opening it up to any questions you might have. Yes?
Thank you. I grew up on Cook and Campbell, and I love them. It's nice to revisit them. One thing I so agree with you and them on, so many projects want to take extreme, categories, extreme groups. So this idea of regression to the mean is such a problem, and that's just, I feel your pain on that because I try and justify, why don't we take more of a continuum rather than just an extreme group. But I had a question regarding the regression continuity.
Yeah.
I've not done that. Is that like a random effects model where you're modeling the slopes differentially, or?
It's so much simpler than that. It really comes down to measuring what happens exactly at that cutoff. So the model, the math behind it, is, if you want to look at the old, where is this? The RD design, basically, at the old version, basically you have the treatment value, you have the assignment, you assign them on this or that side of it, and then an interaction effect of the treatment and the assignment, and then within a given bandwidth. It's really that. So what you're looking at is the difference here, and the treatment effect is just basically on the beta 1 coefficient. It's that simple. That's the old. Now, again, you could play around with the bandwidth, or you can do the local linear regression models. There are tools out there. I don't know what software package you use, but in Stata, there's a program called RD, which is a really well thought out program. But now there's a new one by a researcher at the University of Michigan. He's an economist here, Kat Nail. That's called Robust RD. That's phenomenal. It gives you the estimation. It gives you several different estimates. It controls for a lot of different things. It's my go-to tool for regression discontinuity. The problem is these things are now so simple that you always have to remind yourself of what goes on the back end of it, because now you can just push a button and all of a sudden you get an outcome. But RD Robust is called by Kat Nail, CATTENANEO. Yes?
What does assign mean?
The assignment. So you, if they are, so here you have a cutoff. So are they assigned on the left side or the right side? If they're on the right side, you call it a 1. If they're on the left,
Isn't that the same as treatment?
oh, I'm sorry. The assignment is the value on the cutoff on the continuous variable, and it's normed so that normed. It's normed so that you're talking about the distance from there. So you set it at 0 from there and go plus or minus. That's what the assignment variable is. Any other questions? Yes.
I have a question regarding retention problems, especially among like high-risk population, Medicare population, or people with spinal cord injury. I had 2 studies reviewers really give me a hassle because these people die over time. So I ended up doing open cohort analysis, closed cohort analysis, cross-sectional analysis to convince them my results are valid. Any other suggestions regarding retention issues?
I mean, you basically hit it. I would do the same thing. These are all basically sensitivity analyses, right? So if you're finding the same results, you're doing your outcome, I assume, is survival, time to event, and you've said, I'm going to include everybody. I'm going to include only a subset. I'm going to include those that remain, those that left, those that possibly did. And if you stratify, and you're consistently getting the same results, I mean, I'd say submit to another journal. I do exactly the same thing you did. I can't think of any other way of getting around that.
And as you said, I now I make it like a routine event when I'm doing these type of studies among this population. I just do it ahead of time because I know they would ask for it.
Exactly. And you know what? That's it. In olden days, there were no appendices. You just, whatever you had was in the body of the paper. Now you can say, you know what? For an extra couple hours worth of time, I can run another 150 models, throw in the appendices, and you say to the reviewer, have at it. Anything else? All right, well, listen, thank you guys for showing up. I am available. The best thing to do is just email me. I don't have my email thing up here, but it's...
It was in the flyer, I guess.
Oh, okay, excellent. So feel free to email me if you have questions. My role here at IHPI is, in fact, to help investigators and actually analysts as well to think about their study design and their analysis plan for it. And it's, again, you can see this isn't an easy thing. And you sort of go, every study, you think about it individually, and it's nearly a one-off deal. But if you do enough of these, all of a sudden you sort of get into a groove of immediately thinking about what tools are available, what's going to work here and that. So at least I can help think through that and maybe save you a lot of time in working through your own million different papers that you have that say, oh, maybe this, maybe that, maybe this, maybe that. If you can whittle it down to maybe one or two different designs, and you're golden. All right, thank you guys.